Well, I have straight up 9 o'clock. I see people are still joining, but we'll go ahead and get started just because, you know, we like to keep these on time so we can let you go on time as well. So good morning. June 16th today, Tuesday, for those of you that need that reminder. I do want to give a shout out to all dads out there because Father's Day is quickly approaching. And sometimes we have to find that little stream of ray of sunshine, if you will, in some of these times where we're still, us are still got to make sure that we celebrate our dads any way that we can. My dad's 94 still.
Janine, your audio is cutting out. You might want to turn your video off.
I believe that Zoom is reloading her connection currently.
Okay.
Yeah. So I can go ahead and pick up the ball here and just pass it around for introductions of the hub team so we don't lose any time on the clock. Let's go ahead and start with Tim.
Good morning. First up, Tim Davis, Telehealth Manager, Oklahoma State University Center for Health Sciences in Tulsa, and the Oklahoma representative for HTRC.
Thank you, Tim, and good morning. Evelyn.
Good morning. I'm Evelyn Nelson. I'm a psychologist at KU Med Center and the PI for the Heartland Telehealth Resource Center.
Perfect, thank you. Rachel.
Good morning, everybody. Rachel Mutro with the Missouri Telehealth Network, Show Me Echo, and Heartland Telehealth Resource Center.
Good morning. And Robert, hello.
Hi, I'm Robert Stiles with KU School of Medicine, Department of Pediatrics, and help out with the Heartland Telehealth Resource Center.
Perfect, thank you, Robert. Heather.
Good morning, everyone. My name is Heather Hagan. I'm a telehealth analyst at OSU CHS in Tulsa.
Perfect. Welcome, Heather. Karen. I know she's on, and I can see her. Let's see. I think I saw her on mute just for a second. We can come back to Karen when she gets. Oh, there she is. Karen, we'll get you as soon as your audio gets connected. Well, everybody, I'll continue with a couple of announcements while we're waiting for Janine to get back on with us. My name is Joe Kingsbury. I'm Associate Director with Associate Director of Operations with Missouri Telehealth Network and Show Me Echo. And I'm also listed as Ask Joe Kingsbury at the bottom of my screen here. There's a reason for that. And those of you who are repeat attendees for this particular echo know why. If you have questions after the presentation or at any time during the session, and you'd prefer just to kind of send it in the chat, I'll be happy to read those questions aloud to the hub team so they can address it. All you have to do is go over to your chat, go down to the bottom of your screen, click the chat function, which I see several of you have found it already as you're introducing yourselves in the chat, and select Ask Joe Kingsbury to send me a private message. I'll take that question directly and I'll present it to the hub team on your behalf. Otherwise, if the crowd stays kind of under 30, it's usually pretty manageable just to be able to kind of raise our hands and we can call on you, or the hub team can call on you, and you can ask your question aloud for sure. It does look like we have Janine back. Janine, are you able to hear us? Yep, it looks like it.
I am. I don't know. Was I the only one that went off?
Yeah, your connection stopped, but we're happy to have you back and I'll catch you up. We just went through and introduced the hub team and I told everybody about the Ask Joe Kingsbury feature, and I'll hand it off to you to kind of take it from there.
Well, you did a great job. Thank you for jumping in.
Absolutely.
All right, let's introduce the hub team. Or have you already done that?
We just finished that.
Sorry, I'm just a little stressed, a little messed up when technology like this happens on a telemedicine Zoom. So embarrassing. Oh my gosh. All right. So the announcements, you've talked about Ask Joe Kingsbury. We're approaching 30, so I think we're going to not introduce everybody today. Just make sure that when you want to ask a question that you raise your hand, let us know who you are, and keep your microphone on mute until you want to speak, and go ahead and ask that question, or ask Joe Kingsbury like he explained before. And just introduce yourself before you ask your question too, because we really want to get to know you. The presentation will be available on Box, and so look at that, and our team will also put any case recommendations on Box. I don't believe we have one today, but the value in echoes is the case. I say this every week, and we would love for you to submit a case study for us to discuss. And it could be on anything about telemedicine. And so we encourage you to do that. So I am the lucky one today who gets to talk with you, and let's hope my internet holds out. I don't know what happened there. But I am going to provide you with some information about what HTRC actually does for organizations, and we do something that's called an eStart report. So I'm going to share my screen, and hopefully that will work. And let's see here. Are we good? There, you can see my screen, right? So telehealth post-COVID, I think that's probably the most I don't know, a popular question right now for all telehealth resource centers across the nation is like, what's going to happen post-COVID? And we do need to plan for post-COVID, but at the same time, I wish I had a crystal ball on my desk so I could tell you exactly what's going to happen post-COVID, but I don't. And so we're going to do the best that we can in terms of providing some information that you may want to keep in the back of your mind for post-COVID, so that you can continue to plan. I do want to just give a shout out to all the telehealth resource centers across the nation. You know, we're considered the Heartland. You can go and get some great information from telehealthresourcecenters.org. If you're wanting more information, they have some toolkits available on there. We have webinars that I'll mention later, but I do want to give a shout out because we've all been extremely busy and helping organizations implement telehealth. We do this by a variety of ways with, like I said, the toolkits and webinars and presentations and trainings and that type of thing. So if your organization needs a little bit more help other than these webinars that we're providing, we're happy to do that as well. All right, so let's get back to the eStart. eStart is unique to HTRC. So we're the ones that do this. There are other assessments out there, but ours is actually built with you in mind. And so we always say that in order to be a successful telehealth program, that you need to begin with that assessment. And so what we do is go over all of these bulleted points in terms of the organizational assessment. We look at program development, your operational support, and et cetera. We've talked about many of these things during some of these webinars, so I'm not going to go over and explain everything that we have talked about so far, but it's just to give you an idea of what we can do with your organization. And why we do this is certainly increases internal buy-ins, and it definitely can look at some differing revenue streams, maybe those that you haven't thought of before when we're talking about telehealth. And so we don't want you to reinvent the wheel. We have templates of protocols and policies that we can lend, and you can just put your name, you know, on those, and it does save time when you're developing a program. So enter COVID-19, and what did that do to eStart? Well, it condensed the process, if you will, and maybe left out some steps. And so when we're talking about what's going to happen after, it's probably a good idea that we need to go back and look at some of the steps that were missed. You know, with COVID, we definitely saw a lot of organizations deciding that, you know, instead of the doctor will see you now, that the patient will see you now by telehealth. And they did like extremely fast program planning for telehealth, and really changed, maybe set their organizations on their ear, if you will, by doing this, by implementing telehealth very quickly. So what it may have looked like was this horse race, okay? And they're off, and we were extremely, you know, inundated with calls, with TA and that type of thing, with people starting telehealth, and it may not have looked as pretty as this horse race, okay? It may have looked like the bottom picture with the stampede instead, okay? And maybe horses going in different directions as well. So it really gave the opportunity to start telehealth, but it may not have been as pretty as it could have been if we had a really good plan. I have to throw this in. Bob Marley said, the day you stop racing is the day you win the race. Well, I think that in telehealth, it is a marathon. It is not a sprint. Telehealth is something that you may feel that you're still racing, you know, to catch up with some telehealth, but at the same time, everybody feels that way. And when you've seen one telehealth program, you've seen one telehealth program. Everyone is different. Every organization is different, and therefore their telemedicine program may look a little bit different than yours, and that's okay. We celebrate that. So the eStart assessment and getting started, we take that, we suggest bringing a team together and really looking at what you're trying to achieve for your telemedicine program. And you really do have to keep a variety of people in your circle. Maybe people that you wouldn't normally think of in terms of a task force or a committee, if you will. But it's very important that you involve billing and schedulers, and of course IT, and your marketing department if you're lucky to have that. If not, then whoever does your marketing, whoever does maybe your social media, that type of thing. And then some telemedicine readiness questions that we look at. You know, what are the payment and policy guidelines? And boy, have those changed. And we have really tried to keep you up to date on some of those changes. And they have slowed down just a little bit, but it's still important to know that those changes there's going to be more changes available to us, because we don't know what they're going to decide, even though they would like to keep things the same as they have been. And we may see that for a while, or it may change on a dime, just like the ones that we have already experienced. But do you have the resources to begin a new telehealth program or expand your telehealth program? Do you have a champion? Because it really does take someone who is going to champion that cause for your organization. And we really do spend a lot of time talking about the resources in an eStart assessment. So we talk about the organizational assessment. You know, and some of these questions, you know, people look at me like, okay, why are you asking that? But it's really important to know if you have recently completed a project that you were able to implement, and what were some of the bumps in the roads with that project, and how can we better take this telemedicine program and maybe avoid some of those barriers that you experienced with the last project. So we talk about that. Then we talk about the workplace assessment. Do you have a place available? Is there a location for a telemedicine office for a distant provider, or even maybe the patient, if they're seeing someone, you know, like a specialist from your office? So we talk a lot about the policies and procedures, and you know, that you're just keeping up to date with those policies and procedures. Then we do a technical assessment. Hey, what kind of equipment do you already have that you can utilize? And maybe what are some of your wants and needs? Are you going to need some peripherals at an originating site that's not at home right now that you will need a patient to go to so that that physician or that you can hear and see the patient in terms of their heart sounds or their lung sounds. Maybe they need otoscopes, maybe they need a skim cam for dermatology. So those are some things that we talk about. So you want to decide what kind of services that you're going to provide. You really do need some kind of high level cost estimates for budgets. I know that, you know, budgets are tight. And so what is it that we need to do? Are there some grant monies out there? Are there foundations that can assist with some of these equipment constraints that we have? So create that written proposal, and what that does, and that's probably what got skipped during COVID, is the fact that you don't have maybe a written report or a proposal for garnering this new type of expanded service for telehealth. And therefore, if a grant comes around the corner, you know, what are you going to do? So if you have that written proposal, you are grant ready. Okay, you can just throw that into some of the grants that are available, whether they're distance DLT grants, or whether they're the USDA grants, that type of thing. That helps tremendously to do that work up front. So when you assess those lines of service, you ask yourself, what are the appropriate telehealth appointments that we want to provide? Are there some appointments that are great for televideo and some that are just for in-person, or maybe some that are perfect for telephone? Because we're getting reimbursed for telephone now too. So what is the appropriate place? You know, is home going to work for some of these appointments? And often that answer is yes, especially with behavioral health. But if there's something that needs to be done for, you know, in order to hear a heart rate, that type of thing, or get the blood pressure and the patient doesn't have a blood pressure cuff at home, you know, how are we going to do that? And what is it that you're going to recommend your patient to do? Or, you know, maybe they could provide that. They may be able to purchase some of that, or you may have to find an originating site for that patient to go to in order to get that. So those are the things that you ask in terms of assessing those appointments. Here's a list of things that we talk about in terms of what we need to consider. Is there the provider availability for these telemedicine appointments that you have? Do you need a coordinator? Is it somebody that can take on just a little additional work that is really excited about telemedicine so that they feel like they're contributing to a new project, and definitely somebody that's helping with that testing connectivity. It doesn't always need to be IT. And then scheduling and billing and those types of things. And then we've just talked about the originating site. And will you get paid? That's always the thing that we talk about too. And we'll talk about reimbursement in just a little bit. But those coordinator services could be on the front end where the distant site, the provider is, as well as at the originating site. And so who is going to do that? And a lot of these eStarts, of course, prior to COVID, we didn't even talk about the home. And so now we get to, and that's really exciting. So what types of things can we do for patients at home? We do talk about reimbursement. We're not going to talk about that here because we've talked about it before, but it's always important to know what you're going to get reimbursed for so that you know if your telemedicine program is going to be able to sustain itself. And then other considerations, of course, we've talked about HIPAA, and we don't know what that's going to look like post-COVID. Are they going to require that, you know, we have the secure and encrypted lines and that you not use FaceTime anymore? So those are some of those things that we have to look at, and we have to be nimble in order to, you know, take that and change as we hear those changes in regulations. So in expanding or improving existing telehealth program, I always look at what we call a gap analysis. And the easiest way to do a gap analysis, of course, it's like, what are we doing right now and where is it that we want to go? That's what a gap analysis helps you do. And the simplest way to do that is through the SWOT method. There are other variety of applications that you could use, but SWOT seems to be the easiest one. And SWOT, of course, is strengths, weaknesses, opportunities, and strength, oh my gosh, opportunities and threats, sorry. So we look at those strengths, we look at the weaknesses of a telehealth program, and then we look at the opportunities and see where we can go from here, and then also the threats in terms of, well, is somebody else doing this? Are we going to be the only ones in our area that will be offering this? How can we maybe recruit more patients because we have this telemedicine program? So those are the things that we talk about when we're doing a gaps analysis. And then we look at what are some ways that we can enhance our telemedicine program. Here are some different ways that we can use primary care use cases for telemedicine. And maybe you hadn't thought about that before, or maybe it's something that you've always wanted to do and now you have the opportunity to really make that plan. So there are a variety of clinical use cases that we can use. Wellness exams, of course, can be done by telehealth. And I think that's an excellent way to keep in touch with your patients, especially during COVID, that they can do some of that from home, and then you can order lab and they can go to a lab site in order to get those. And then you can give the results over a telephone, or you could even do it over televideo. So there are a lot of different ways that we can use telemedicine. And this is just an example of what a wellness, annual wellness visit would look like via telemedicine. And I won't go through that, but there are different screenings that you can certainly do for telemedicine. All right. So getting started, again, step 3, we've gone through 1, 2, and 3. We're at 3, developing a business case, providing that really well-written business case so that you can present this to maybe administration, maybe it's a board that needs to give that approval, and so that you can look at how this can get started. Now, the HTRC doesn't do this for organizations, okay? We guide you through the things that you need to have in this business case. Certainly those that are large organizations can hire a consultant and pay them to do that, but the HTRC is here to help guide and give technical assistance to your own program, and so that you know that you've done the work actually. And we think also that when you do the work, you're more invested into the success of the program. Step 4 would be that detailed implementation plan. That's where you get those protocols. That's the guidelines. That's where we try to provide you with some templates so that you don't have to recreate the wheel. And then you give that detailed technology plan and a performance monitoring plan too, because you've got to have quality improvement there as well. And then it's implementation. And that's when HTRC kind of steps back, because you're implementing your program now, and then we go back and help somebody else start the process over again. But this implementation is what everybody wants to do, because it's the fun part, right? Planning isn't always the funnest thing that you've ever done in your life. And there's some bumps in the road and that type of thing that you may get to when you're planning, but the implementation is really what everybody's final goal would be to get to. And that is definitely something that's exciting. But I always say implementation, you have to think about marketing. You have to think about how are you going to let your patients know that you're doing this great telemedicine program. And so that's why it's important. Not all organizations are lucky to have a marketing person, and it may be somebody that just kind of does it on the side, but somebody's got to be able to keep up your website and let them know about your program, your newsletter, whatever it is. And then also social media is a great way to reach your patients too, and let them know about your new program. I always like to end presentations on telemedicine with this picture. The reason is because, we're kind of in that gardening season right now. And it's important to, truly love what you see, whether you're planting a bed of flowers or a garden or a tree, that, you really want to see, and your neighbors want to see that beautiful tree, but it takes work to make that tree or that garden or that flower bed flourish. And in order for it to flourish, the root system has to be well established. And that's why we do this planning process, because when you just stick something in the ground and you don't take care of what's underneath, all right, then it's going to fail. And you don't want it to fail when you put all of this work into it. So that's why all of these roots have to be well identified, well explained and talked about in some of these meetings that you would have when you're planning telehealth, and so that your tree or your telehealth program will flourish. So what are some lessons learned? Equipment doesn't have to be the most expensive to be the best, and we talk about that ad nauseum. It seems like you don't have to go out and buy a robot in order to be a telemedicine provider. Learn from others, and that's what we're doing right here with this telemedicine echo. And that satisfaction scores have been high for telemedicine, especially from home these days. It's still medicine. Technology is a tool. I really love to say that someday maybe we'll just call it medicine and not telemedicine. And we have to plan for it, and you have to practice for telehealth as well. And I think I talked about this earlier with the horse race. It's really not a sprint, it's a marathon. So it really is something that you have to keep working at and keep those quality improvement structures in place so that you can continue to improve. I do want to give a shout out to some webinars that we have coming up. July 7th is the next HTRC one, and we're going to talk about veterans and rural telehealth. And then the National Consortium of Telehealth Resource Centers has another webinar, Making Video Visits Personal, Implementing and Scaling with Your Own Providers, which I think is going to be excellent. And that's on June 18th. You register for that at telehealthresourcecenter.org. So that will be at 1 o'clock Central Time this week. And then don't forget to look at the heartlandtrc.org webpage for updates on a variety of information, not just COVID, but things that we're putting up constantly. And there's my contact information if you need more. So I'm going to stop for now and open it up to questions and discussion.
So we don't currently have any questions in the chat.
All right.
Actually, I take that back. We just got one. How do you suggest collaborating with other providers in the area to help them see how telehealth is reaching new and different patients than those who already obtain services at their in-person sites?
Oh, wow. That's an excellent question. And the collaboration piece is, well, it's difficult at best because we're so busy, and we want to collaborate, but we have to take the time to make sure that we do that collaboration and do the hard work of working together and making sure that what we're offering is what the patients need. You can offer a telemedicine program, but if you don't have anybody coming because it's not what they need, but it was the easiest one for you to do, it's not going to make a difference in your telemedicine. And what was the second part of that question, Joe?
How do you suggest collaborating with other providers in the area to help them see how the telehealth is reaching new and different patients than those who already obtain services at their in-person sites?
Okay, all right. I think that was addressed, but that's, yeah. Rachel, do you have something
I
to
just had a
add?
thought on that. Sometimes we like to see this growth be patient driven. And so as much as possible, encouraging the patients to ask for telemedicine services, I think is a good way to, you know, do the grassroots.
I agree with that. That is definitely something that we need to keep, you know, whether it's a patient survey or it's just word of mouth and that type of thing, or that they're asking. A lot of telemedicine programs have started because the patient was in need of a telemedicine instead of driving 5 hours to an urban area to see perhaps a specialist, you know, and they couldn't swing it. So a lot of those telemedicine programs start like that. Very good.
We've got another question for you, Janine.
Great.
What is the role of QI and evaluation as programs roll out their implementation plan?
Yeah, well, quality improvement is something that you have to consider, and whether that is a few short questions that maybe a telepresenter would ask a patient, or actually, you know, a survey that you end a clinic visit with in terms of telemedicine, it's incredibly important, because if you are offering this and you have no idea if the patient's getting anything out of this or not, maybe you feel like you are, but maybe the patient isn't, or vice versa, okay? And so it's important that you keep those lines of communication open, however you try to do that evaluation in order to improve that program. Continuous improvement, you know, that's been a mantra for a long time with many, many programs, and you cannot escape that with telehealth as well. So you've got to do that. A lot of times what we've done in the past is do just like a little survey. Did the technology work? Was the provider, you know, did the provider give the appropriate information over, you know, did you feel like, would you do this again? Would you tell friends? Those types of questions are certainly those that you could put into a survey for quality improvement.
Perfect, thank you. Do you have any tips or best practices for training providers on using telemedicine across service lines or getting them on board?
Well, you know, I think COVID helped a lot with that, because it was all of a sudden they were slung into it. All right. There were many providers that just didn't see the value of telemedicine, or they just didn't even have time to do that. They've had a little bit of time now. And so I think it's just important for everyone to take some time to look at what providers can offer, and get them on that so-called committee if they have some time to do that. I know that there's going to be maybe some telemedicine programs that don't continue after COVID because they didn't have a good experience, and because maybe they faltered a little bit in some of their telemedicine offerings. And so, but that's okay. I mean, if it didn't work, it didn't work. It doesn't mean you can't try again, or maybe go back to the drawing board and plan in those steps to make sure that you're not leaving out steps. And some of that is getting the providers on board. That's, you know, that's been the hardest thing, I think, in telemedicine for a long time. People have to want to do this. And I'm definitely want Karen to weigh in on this. She had her hand raised.
Yeah, I just wanted to weigh in on this. And this is my personal opinion, okay? This is not the opinion of the HTRC. I just want to say that up front. But I really believe that watching the field that in some ways the systems like the University of Missouri, who kind of didn't give up, but turned away from their legacy sort of effort to integrate one of the direct-to-consumer company platforms with our electronic health record. And those things take a long time. They're technologically difficult. I think a lot of this has to do with the technology, quite frankly. And Zoom is so frictionless, even though we do have problems occasionally, like I had to sign back on today because my sound dropped. But it's so frictionless that I think people who start out using something Zoom, they can see how easy it is and how, you know, and they're doing meetings on Zoom and they can see how easy it is and how frictionless it is and how intuitive it is. I think those programs do better. And I think the programs where in the systems and the organizations where they're trying to force the providers into using clunky, non-intuitive, difficult technologies, those tend to be more difficult because, you know, doctors and other healthcare providers are busy and we want things to work right the first time, right? And we don't want to be forced into some clunky technology because that's what the administration wants or the financial people want or the technical people want. We want it to work. We want it to work now. And this is my opinion, okay? Just personally, my personal opinion, but it's got to be easy and it's got to work well. And you got to be able to do what you need to do. And I think Zoom has had a huge impact on this. That's just my personal opinion.
I think that's excellent. I think that's an excellent opinion, if you will, because I've seen that too. If it's not easy, they're not going to do it. Any other questions? Oh, Joe, you're on mute. I can see.
What, you can't hear me? So, does HTRC have any templates on calculating the return on investment for implementing a telehealth program?
Ooh, that's a good question. We talk a lot about return on investment, but as far as a template, that's an excellent suggestion. So we definitely will work on something for that.
And this is Rachel. We might be able to find one from one of the other TRCs. So we'll be on the lookout for that and we'll be able to share it with this group if we can find something good.
Absolutely.
Thank you. Next question for you. What factors do you look at in deciding on which clinical service to start with via telehealth?
Okay, so prior to COVID, I would always say, and I would say this during COVID too, start small, do one thing, do it really well, and move on to the next. So grab that low-hanging fruit. What is it that you could implement quickly and get reimbursed for it so that you do have some return on investment? And that way you can build on it. And it's different for every clinic. Okay. So because there are specialists, there are primary care, whatever. It could be diabetic nutrition education that you offer first. And you get that off the ground, and then you maybe go into some clinical telemedicine. But it's definitely different for everyone, but I do suggest talking about that low-hanging fruit, what we can do quickly and make an impact.
Thank you. Next question, what are the statistics on no-show rates for telehealth visits?
Wow, that's a really good question. I don't have statistics right at my fingertips right here, but I do know that we have discussed this, that the no-show rates really decreased when telemedicine was implemented. But does anybody else have anything to back that up with?
I don't have anything to back it up with, but I will say that historically, when we did telemedicine in kind of that old legacy way where it was for specialty care in underserved areas, our no-show rate was higher, but a lot of that was because we were seeing underserved folks who sometimes have more trouble with, because they would have to drive to a clinic or something like that, and they have trouble with transportation, and just, you know, they have other pressures. They have kids, they have, you know, just all kinds of other pressures. And so the no-show rate was higher, but now that everybody's using it for their patients, then what I've heard anecdotally is the no-show rate is much, much lower because people can do it from their homes, so they don't have to go somewhere. So the bar is lower. So I think we're going to see that the no-show rates are going to be a lot lower in this pandemic climate. That'd be my guess.
This is Evelyn. I can comment from the behavioral health perspective. Exactly what Dr. Edison was describing is what we've seen in our behavioral clinics, where we still have families who may forget or time gets away from them, but then in contacting or texting them, you know, they're able to just jump right on, where, you know, in the past they would have had to, you know, drive, park, come in. So it's helped with that component. I do think sometimes telemed gets an unfair rap where, you know, it does have no-shows and cancellations just like on-site clinics. So I think getting those two comparison rates can be helpful, so folks aren't confusing that only telehealth has cancellations or no-shows, or kind of overestimating that both types of clinics are going to have no-shows and cancels.
This is Candace Shaw. We had some hard data. It wasn't ever published with a pediatric urology group that was able to, by implementing their telemedicine virtual visits, reduce their no-show rate from about 40% to about 10 to 15%.
That's impressive. Well, I think we're going to see a lot more of that. I know that people are, you know, proposing research projects through grants and that type of thing to help us understand what happened during COVID, with home being an originating site and that type of thing. So I look forward to that as well. But thank you for that information. I think it's very much appreciated.
This next question is certainly well geared toward the folks on the hub team who work at universities and other learning centers. Any thoughts on how to incorporate telemedicine in an academic medical center setting with student learners?
That's something that's near and dear to my heart, because I think that we really need to up our game with our students in a variety of disciplines, if you will, in terms of telemedicine, helping them become familiar with it. A lot of times they're familiar with it because they're users, all right, but not necessarily the providers. I really believe in some simulation exercises for our students in order for them to become comfortable with it. I do know that some students' experiences are with maybe it's their preceptor during their residency. I mean, you know, there's just so many different ways that students can learn. But I do believe it needs, this is my opinion, okay? I'm gonna take Karen Edison's advice and say this is my opinion, but I do believe that we really need to formalize some of this telemedicine education in order for it to move forward. Rachel, did you have something to add to that?
Just a couple things. I think you're right on the same track of thinking that I was, is to try to look for the opportunities for where telemedicine can easily fit in. And in simulation centered with standardized patient care, the medical students have the opportunity to do that. And we've been able to create a case or two here at our medical school so that the medical students couldn't do that. But I don't know how, I think it's optional for them. I don't know how often it would be in their rotation. And then the other thing, just one other thing, Karen, and then I'll let you go. We started implementing telemedicine into our resident programs back in the early 2000s in both psychiatry and dermatology. And so they were a formalized part of the competencies that the residents had to get through. Obviously, that's not as early as the middle. Let you go.
I was just going to say, I have to turn my video off because my internet's unstable. But I was just going to say that, you know, for decades, like whenever I talk about telehealth, I like to think just like it is in person. And so just like in person, for decades, we had students go in and interview the patients, come out, present just like in person. So it's interesting, a lot of the students that rotated with us, and then a lot of the residents, we've had residents and students involved in telehealth for a long time. And then you look out over the landscape and they're the ones that end up doing it where they go. So it really, I think we do need to normalize it as part of everybody's experience.
I think looking across professions when we're looking at the training is great as well. In behavioral health, you know, with psychiatry, psychology, social work, behavioral analysts, you know, and now we're integrating some of our interprofessional students with OT and others. As much as we can train across professions, I think it really hits what Dr. Edison said. You know, that's the folks we see then practicing.
Hello, this is David Moran. I'd have to agree with that. As a matter of fact, it's kind of interesting in that the ACGME for primary care, at least now, is requiring a certain number of minimum telehealth visits and putting that in as a residency program requirement on the report. So we were really thrilled in a way that COVID allowed us to do this, because prior to COVID, we didn't have a good mechanism to do that or offer that training to them. But now it's part of their usage. One interesting thing is that our usage of telehealth has dropped down to about an average of 20% of the visits now that we're almost back up to full volume in face-to-face visits. So it'll be interesting to see the dynamics of how this works out over time as to whether we continue at that level or whether it rises or even goes to a lower level vis-a-vis the face-to-face visits. And right now, it's not reimbursement issue that's driving it. It's actually patients wanting the face-to-face visit. We offer them both. But I think Jackie Griffin is online. She can probably talk to this on other non-primary care clinics and see what she's seeing.
Yes, I'm here. And Dr. Moran's correct. I think we're trying to figure out a path and a strategy. The content was really terrific today for us because we're trying to figure out a strategy going forward. I think the way I'm describing it is now post-COVID, we're going to have some clinics who probably aren't going to do much, if any, telehealth. And we're going to have some clinics that may go to almost all telehealth. They may have used it, loved it, and said, this works great for our practice. But what I'm seeing in most clinics is that they're going back to primarily seeing patients in person, but they're supplementing with telehealth, and they're comfortable now supplementing with telehealth. So they're looking at their highest risk patients and the patients that really they don't need to see face-to-face, that they can have really quality telehealth visits with. And then how do we ensure that they, again, we came out like the horses from the gate, just like you described, but now how do we back up a little bit and say, let's look, let's truly define in each clinic. Right now we have telehealth going in over 30 clinics or specialty areas. So it's backing up, taking a look at each one of those areas and saying, where do we go from here? And how do we now have put in better workflows, ensure everybody has the equipment that they need. We, you know, as we were going out full force, it was like, if you have a tablet or a a laptop that has a working camera and microphone, go. Now we're like, okay, that's not the most ideal setting. You want to have dual screens so you can have the medical record up. And if you're primarily doing telehealth, you want to have a better setup than that. So it's backing up and looking at all that. I did want to mention, I put in the comments that corporately here at Truman, we saw, and this is anecdotal, it wasn't anything official, we saw our no-show rates go from corporately about 40% when our clinics were running. But the height of COVID, when we were primarily doing telehealth, our no-show rates were running between 10 and 15%. So.
Yeah, I have to agree with what Jackie said there. I'm in the primary care clinic, and our no-show rate for video and telehealth visits is half to a quarter of what it is for face-to-face visits.
Very good. Thank you for that. Joe, do we have one more question?
We do have more questions. Next one is, have you seen an influence of artificial intelligence on telehealth?
Yes. Yes, and I think our technology presentation may have touched on that. I have not seen just here in our area, other than some behavioral health programming that's using some artificial intelligence to assist with some group dynamics with children with autism and that type of thing. So I really do believe that that's, I'm not going to say the next frontier, but definitely something that is already happening, that more and more people will catch on to that. So it's been helpful in behavioral health, I do know.
Perfect, thank you. Next question. How has the check-in workflow process changed when considering the interactions between the registration desk and scheduling in a telehealth encounter?
Well, that's a really good question. And I would like for people in the clinic to be able to weigh in on that, because the changes that occurred during COVID, you know, I've not been able to experience because I've just been doing, you know, mostly TA, but I want to hear what kind of changes you've experienced in the clinic setting.
Hey, Jackie, you ought to jump in on this because I think you developed a pretty good plan.
Can you specifically ask me the question again?
I certainly can. How has the check-in workflow process changed when considering the interactions between the registration desk and scheduling in a telehealth encounter?
Ooh, okay. So right now here at Truman, we have multiple platforms going. And so initially when we came out of the gates, it was a mess. Patients weren't getting registered, docs were seeing patients, our registration billing folks were having to go back behind the scenes, register them after the fact. There was a call center put in place. So a lot of our financial folks, their jobs kind of came to a halt when our clinic volumes went way down. So they put in a call center that works wonderfully. So they're reaching out to patients once they're identified as a televisit, reaching out to patients, ensuring they have the correct app put in place, on their phone, so that the doctor's not having to help with that, be it Zoom, or we're using another platform called SiteCall in some of our clinics. And so they're reaching out to the patients, making sure they're comfortable with the app. I'll specifically speak to the family medicine clinics where we're using Zoom. We started working with the clinic staff. Again, it's being, let's just say it's being mastered. We're not anywhere near perfection, but the staff are learning on how to schedule the Zoom visit, look ahead in the schedule, send out the links ahead of time so that the doctors don't have to, at visit time, all they have to do is log in and click their link. So they're setting up the Zoom appointments with the patient ahead of time, ensuring that the patient is on ahead of the doctor. And then they can share the visit with the doctor as the alternative host, be it a resident, be it the faculty or attending staff. And I think Dr. Brand's clinic, primarily because they have Dr. Brand in there to help them too, is kind of been our pilot clinic, and they're working out the glitches for us. I think long term, this will be a great model. to where we can set up the patients like they're in a waiting room. And it to mirror the workflow of an in-person visit. I sit on webinars all the time, and that is something that most people will say is you want your televisits to look like your in-person visits so that the flow looks the same. And we're gradually getting there. The challenge is that we do have so many different clinics and all of them function differently. And so it is, we actually have made a timeline for the next 10 months to a year that we're going to go clinic by clinic. So me and one other individual, Allison Trout-Ryan, she's on the call too, are going to go clinic by clinic and look at their workflows. And some of them, we're going to make a broad workflow that can be replicated, and I say with tweaks. Because a podiatry clinic is going to do telehealth much different than a dermatology clinic, much different than a family medicine clinic, much different than a behavioral health clinic. And so if we can put a broad frame out there that includes registration, scheduling, billing, the actual visit, all of those pieces, and cover it all so that people aren't like, hey, we don't know what we're doing here with telehealth. And they have a guide that guides them through it. So that's our big challenge for the next year, is that we want to make sure everybody understands the workflow in their clinic and it mirrors what it looks like when a patient comes in person.
Yeah, it's a real good work in progress, and it'll be interesting to see what involves. But I think we're going to be faced with a change in medicine from this 8 to 5 clinic-based stuff to a 24/7 medical environment. And so I think the future, when I look out, especially as some big companies like Amazon and some of the others get involved in this, we're going to see a totally different type of on-demand primary care. At least that's when I look in the crystal ball. So we're going to have a totally different view of the patient rather than this episodic encounter-based interaction that is going to be boundaryless. And so it wouldn't surprise me if insurance companies don't get into the market and big organizations get into the market and they actually do the venue so that you're seeing somebody in a more comprehensive fashion involving many, many people at all hours of the day based on the convenience of the patient. So it'll be interesting to see how we get to that from where we are now.
Well, I really appreciate this discussion today, and we're closely approaching the end of the hour. Thank you for all of your input. I really appreciate it, but I'm going to hand this over to Rachel at this point so that we can discuss future echoes.
I just wanted to put out a call, and I put it in the chat box for you to tell us what topics you would like to hear about. We've gone through behavioral health, we've gone through some specialty care things, we've gone through a lot of reimbursement and regulation talks, and Janine did a great job today going over the eStart program that we utilize in HTRC. But we'd really like to hear, you know, what kind of information that you feel like you're still lacking. And you can either just shout it out or put it in the chat. I know we've only got 2 minutes left.
Yeah, I would like to have a session devoted from the patient's point of view, because we're having some interesting conversations with patients as to their preferred modality. And I don't think we really understand the patient's experience with this as much as we'd like to. I can tell you an interesting anecdote. Back when I was involved at KU and we were doing these very early visits, we had video cassettes that the visit would be recorded on. And the patients were given the video cassette, and then the next visit they were to come back and they would record the next session. So we'd have these half-hour visits on telemedicine that the patient would be recording. And the patients loved bringing friends over and sharing that visit with them. And so I'd like to see what the perception and thought is from the patient, and a variety of patients. It would be interesting to see what they expect, because I think we in medicine are biased.
That's really great. Thank you. We will see what we can do to provide some different patient groups and their perspective. I think we can try to figure out, you know, from the parent perspective or from someone in a very rural area perspective. There's lots of different angles we could go at with that. So thank you, David. Anyone else? I see one on school-based telehealth, maybe, Jackie. So we could look into that as well.
Yeah, we've been approached and asked, I'm sorry, I typed that up because I didn't know if we were going to run out of time, but we've been approached and asked if we would consider establishing a program in one of our local school districts. It's a very large school district, to include physical and behavioral health virtual clinics within the school. We're definitely open to that and interested in that. But any models that are out there, I think Cox Health is doing some of that in the Springfield area.
Cox does and Freeman does down in Joplin, and then in Central Missouri, there's a program as well with Live Well Community Health Centers. So certainly we can figure out one for that.
Thank you.
All right, Janine, I think we got a couple good topics. You're muted.
We'll see you next week, okay? Thanks for joining us. Bye.